Thank you very much. I'd like to thank the organizers for putting this wonderful symposium together and inviting me to give a talk on pain, which is quite a daunting task. As you heard Dr. Greenberg, this is one of the more challenging symptoms that's ubiquitous in many CNS inflammatory disorders. And so in the short time that I have, I'm going to try to give you sort of a potpourri of the various pain syndromes that we see in these various conditions, many of these pain syndromes that the audience suffers with. And in my sort of day-to-day life treating patients, I would say pain is probably one of the most difficult symptoms to treat. And I hope if you remember anything by the end of this short presentation, you remember that treating pain really takes a multidisciplinary approach and a multifaceted approach. And it's not just about the medications. We have to think outside of just medicines. So I have no relevant disclosures to this particular talk outside of I'm not a pain management specialist, so that's a little bit of a caveat. So this is a neurologist's point of view. I'm going to briefly talk about two of the standard definitions of pain that many people agree about. I'll spend a few minutes, not even a few minutes, probably a minute on basic characteristics of pain. And then the majority of the time, I'm going to review the various pain syndromes that we see in CNS inflammatory disorders and really focus the attention on the spinal cord related pain syndromes because in my view that really seems to be where the trouble comes from. And then we'll briefly talk about some of the treatments that may be successful. So in the late 1960s, a pain specialist nurse, actually Margot McCaffrey, defined pain as what you see there. Whatever the experiencing person says it is, existing whenever and wherever the person says it does. Now, I really like this quote because I think it does encapsulate in a broader way what pain is versus the American Academy of Pain Medicine. And I told you I'm not a pain management doctor, so I can sort of bash this a little bit, but an unpleasant sensation and emotional response to that sensation. Now, it's quite vague and doesn't really provide a lot of information, so I like Margot's quote much better. Now, characteristics of pain, I think many of you could go through this and tell me what it is. Pain is very complicated. It is a sensory phenomenon. It involves a lot of different parts of the central nervous system after it's been damaged. And you saw very nicely Dr. Pardo going through the anatomy of the nervous system. And when there's a disruption within the sensory pathways, as we see in transverse myelitis, that sets up for future pain syndromes. Now, the problem with pain, as you know, and when you go into the clinic, we ask you, well, what's your pain out of 0 to 10? It's a useless scale, it really is, because it really does not help the clinician get a good idea of how severe the pain is. And unfortunately, still in this day and age, we don't have very good ways to measure pain. There is this visual analog scale that's a little bit better. It's out of 100. So some of my patients, I will ask them out of 100 where your pain is. Scales can sometimes be useful if you're with a provider longitudinally. They get to know you, you build a relationship, and then you can see exactly where that person is on those scales to say, all right, are you having a good day or a bad day? So it has some utility, but not a lot. And pain, interestingly, is very individualistic. There have been a number of studies looking at why do some people have pain show up in certain ways? Why is it more severe in some individuals versus others when they have the same exact attack in the central nervous system? And so some of this may be how you grow up and how you are taught to deal with pain. So it's very complicated. And why do we care about what the primary etiology of the various pain syndrome or syndromes is? So we can target the therapy accordingly. And I'll go through some of that in a little bit. So transverse myelitis pain or myelopathy, as you heard, comes in really two flavors. It's the acute pain, where some of you who have had TM, at the onset, you'll have severe back pain that comes with it. But I would argue that's the chronic pain syndromes that really are the most difficult to treat and the most problematic. And across the board, the majority of people who have had some spinal cord attack will have some pain syndrome. Now, many of you can tell me, and we hear this in the clinic, that there are various triggers to the pain, and you can see the list there. So if you don't get a lot of sleep one night, you wake up the next day, you may be in more pain. If you have an infection or you're exposed to excessive amounts of ambient heat, that may provoke some of the pain. And there have been a few studies, not a lot, but a few studies that have demonstrated that the severity of the attack does correlate to the severity of the pain syndrome. For example, we know with certain conditions like Neuromyelitis optica, where the spinal cord attacks that occur can sometimes be a lot more robust and cover a larger area of the spine versus MS, that the intractable pain syndrome seem to be worse for that condition, at least based on a couple studies. So I'm not a radiologist, so I have a lot of disclosures. I didn't realize. So I'm not going to go through this in great detail, but this is just to get the point across that pain syndromes often are more significant with the worst TM attacks. So this is a patient of mine who has neuromyelitis optica and suffers daily with a variety of pain syndromes. This is a patient of mine who has multiple sclerosis, who does have some pain syndromes, but it doesn't seem to be as severe as the NMO patient. So this is a busy slide, but when we look at pain syndromes, at least when I look at it, I'm trying to think of categories. So where does this particular pain that a person comes in with fall within these categories? And so we break it into primary, secondary, and tertiary pain syndromes. By and large, the most common is primary pain syndrome, so it's directly related to the neurological attack and the injury that ensues from it. Some of the things that you know well, neuropathic pain, tonic spasm, and spasticity, so I'll go through a couple of those in more detail. The secondary pain syndromes and also the tertiary pain syndromes, at least from what I've seen, often are not paid attention to. And I think it's very important to be mindful that not all pain is neuropathic pain. So there certainly could be a musculoskeletal pain component. If someone has had a spinal cord attack and their gait is off and chronically your gait is not functioning normally, that's going to put wear and tear and stress on various parts of your joints and body that aren't used to having such a load, and that over time will cause many problems. The tertiary pain is, I wish we could have a whole symposium on tertiary pain. When individuals have chronic pain syndromes, it develops into a very bad vicious cycle, including emotional issues, depression. I don't have to tell the audience here. It's very, very challenging. And what I do try to relay to residents and fellows is that if someone has chronic pain, you have to look at these secondary and tertiary pain syndrome categories and treat those just as much as you're treating the primary pain syndromes. Else you're not going to break that vicious cycle. So within primary pain, neuropathic pain really seems to be the most common. And of course, it's at some level the most disabling because, as you can see there are many different ways we will describe neuropathic pain, or you guys will describe to us the burning, tingling, squeezing sensation, electric shock-like pain. I saw someone just this past week who has, well, and I'll go through this in a little more, but has Lermite, a Lermite sign that every so often it just comes back with a vengeance. No new lesions on MRI, it's just from prior damage, but this is one of the most disabling pain syndromes that she has, and so we're currently actively trying to modify her pain treatment. The challenging thing with neuropathic pain is that not only can it be continuous, but you can have the severity change throughout the day. So you may wake up in the morning and feel, oh, not so bad. You go to work or you go to visit a friend, and all of a sudden your pain levels go through the roof because of the activity that you're doing for that particular day. And it's somewhat unpredictable. The one thing that I hear in clinic that is probably, I would say, one of the most challenging things with neuropathic pain is, so here you are, you're coming home ready to lay down in bed and go to sleep, and boom, there it kicks in. And you can't get a good night's rest. Then the next morning, you're fatigued, then that revs up the pain syndrome again. It just continues. What we'll see some clinicians and some patients doing on their own is trying to take over-the-counter ibuprofen, Aleve for neuropathic pain. Because of where the injury is occurring and the type of receptors that are involved, these standard analgesics actually do not work. And as I have alluded to already, it does really take multiple therapeutic interventions to treat certainly neuropathic pain and others. So still within the primary pain category, there are the intermittent pain syndromes. And I've mentioned already the Lhermitte's phenomenon. I don't know if, maybe I'll raise your hands. Have any of you experienced sort of this Lhermitte's phenomenon where you flex your head forward and you get just this bolt of lightning right down? It's quite disabling, quite problematic, and it will just happen. You'll be out, having lunch, you move your head the wrong way, and boom, zap, you get it. It can be very uncomfortable, and anatomically, it's the back part of the spinal cord that gets involved. Now, this doesn't necessarily go hand in hand with just neuroinflammatory conditions. If someone has bad disc disease that's compressing the back part of their spinal cord, they can get a Lhermitte's as well. Painful tonic spasms, I've seen a number of individuals who this was their presenting symptom of their neurological condition. And there was actually a nice paper that was just done, and I think our group, led by Dr. Levy for NMO, looked at tonic spasms as being very disabling and actually could be the presenting symptom of a condition like NMO. They're very brief, but really painful. Now, this multiple sclerosis hug, we have to get rid of that because I think anyone who has a spinal cord attack, you can get this torso band-like discomfort. And I've had individuals in clinic tell me that they can't breathe when this really comes on. And this can be very disabling as well. Sometimes can respond to medications that we prescribe for neuropathic pain. Now, I've already touched a little bit upon some of the symptoms that we'll see with the primary pain syndromes. Insomnia, anxiety, depression, weight loss, of course, decreased quality of life. There have been a number of studies showing that chronic pain syndromes really significantly impact one's quality of life, and then disturbed relationships as well. So how do we manage primary pain syndromes? As you've heard me, and it's going to be over and over, that we really need to look at this from a holistic approach and try to treat people with a multifaceted approach. So medications, you can see the various classes of medicines there we will use, and they target different areas of the nervous system, different receptors, different channels. Often we need to do a combination of these medicines with different mechanisms of actions to help treat the pain. Depending on the type of pain syndrome, sometimes warm and cold compresses will help. Pressure stockings, acupuncture. I have a slide dedicated to medical marijuana since it's all over the news. And when we look at refractory pain syndromes where we have someone on multiple medicines, they're doing acupuncture, they're doing massage therapy, they're doing the warm and cold compresses, and we're still not making ends meet. We will think about spinal cord stimulators. There's older ones and there's a newer one that actually it seems to be MRI compatible, which is good because we like to do MRIs on our patients. Then there are the barbaric interventions, which I personally have not referred anyone to, where actually parts of the spinal cord are chopped out from the neurosurgeon to try to help decrease pain syndromes. And at least the studies that I've reviewed, the problem is even when you chop that area out that you think is the focus of the pain syndrome, up to 30%, even more, actually have the pain syndrome come back, and it can be even worse. So I don't typically refer people for those. Now, there are other interesting techniques that are being used in the peripheral nerve world, these radio frequency ablation procedures for root disease. I've had a couple patients actually undergo that, and sometimes it helps. So we're going to go over all of these medicines in great detail, exactly how they work, and then there's going to be a quiz at the end. Now, believe it or not, this is a shortened list of the various pain medications that we will try in people. And on the prior slide, when I showed you the different classes of medicines, these are some of the medications that are in those classes. Now, what the good news is, when you try one medication, it doesn't work, there's clearly many others that can be tried. Often we do have to do a combination of treatments, though, 2 or 3 medications actually at the same time at different dosages. And it can change over time, too. So as an individual gets older, their body changes, and so do their pain needs and their pain intervention needs. With respect to pain medications, though, at least my approach to this is that I really try to start low, the lowest possible dose with a particular medication, and then gradually titrate it over time. Reason being is that these medicines have some significant side effects. And so if we just put you on the maximum dose right from the start, you're not going to be able to tolerate it. We're not like the epilepsy guys where they bring someone into the epilepsy monitoring unit, they rip the medication off, they titrate up medicines really fast because that's in a controlled environment. We don't have the luxury to do that, so we have to treat this as an outpatient. Now, I've already alluded to that most people will need more than one medication to help with the pain syndromes, especially the more refractory ones. And I would recommend, if you're going to do multiple medications, to look at the various mechanism of actions of the drugs and try to target the pain from different places, of receptors and at the channel level. That's for your clinician and other providers to figure out, but this is a good rule of thumb. Now, this last bullet point, I put this in here because some people will get some pain relief. And for the chronic pain syndromes, especially the neuropathic pain, I don't think that bullet point really relates to that. I think sometimes in the acute setting of back pain, we'll put someone on medications that we can taper off. But most of the time, that last bullet does not seem to apply. So secondary pain syndromes, musculoskeletal pain. Yeah, it's like driving a car, right, with square wheels. It's quite challenging. So musculoskeletal pain really, I think, goes underdiagnosed. And if I see someone in clinic that has ambulatory problems, or maybe is not ambulatory based on their attack, but is in a wheelchair or whatever their mobility is, I start to ask in a little more depth, about the pain. Where is the pain located? Oftentimes in musculoskeletal pain, even though it can be diffuse, it's often localized to one area. Maybe it's the hip, maybe it's the knee. This is extremely important. I missed Dr. Becker's presentation, but we work closely together, and he is from the neuro-rehab perspective. We send a lot of people to our physical therapists, occupational therapists, neuro-rehab specialists to try to help treat this class of pain syndromes. And like I mentioned, for many people, they'll be in the multiple different boxes, primary, secondary pain, and tertiary pain. So you have to treat all of them independently but together. Now, there are some issues that are iatrogenic, where if you have multiple attacks of TM or central nervous system attacks, we often will give steroids, right? And there are some people in the community that will keep people on steroids for a long period of time. There's this condition called avascular necrosis, which is basically like a stroke of large joints like the hip, the shoulder, the knee, which I've seen in several patients. So we are sensitive to that. If someone is having severe hip pain, we may need to do imaging, including x-rays and MRIs. So how do we treat these secondary pain syndromes? Prevention is the key. So if someone has disability where their gait is impaired, for example, getting involved in a very aggressive rehabilitation program is going to be key, because that will help prevent some of the musculoskeletal strain that the person is destined to unless you're keeping active and keep them mobile. That old adage, like, if you don't use it, lose it, it's really, really true when it comes to these secondary pain syndromes. I'm not going to go through that list under the PTOT assessments and interventions, but know that there are various things that can be done. Other things, non-pharmacological, aquatherapy, seems to work really well for a lot of people, even those that have higher disability levels, because in the water there's no gravity, so you can actually move in the water and move through joints that may not have been having much movement for years. I endorse, other things like manual manipulation, acupuncture, yoga, et cetera. Now, the medications for secondary pain syndromes, when we're thinking about musculoskeletal issues, we do use a variety of medications, but this is where the anti-inflammatory ibuprofens, Aleve sometimes can help. Problem with that, though, of course, if you take too much of it, you're going to get rebound headaches, you're going to get a stomach ulcer, sometimes kidney failure, so you have to be careful. And you can see the other list. Sometimes we'll use narcotic pain medications, which I'm not too fond of, and then to try to help improve bone health, vitamin D, calcium, et cetera. So I'll spend a couple slides on spasticity because this creates a lot of pain, and often the spasticity that results, you may, at least I've seen in clinic, where someone looks like they're extremely weak, but actually it's because their spasticity is overriding, and once treating the spasticity, they're able to move freer. So those pathways that Dr. Pardo was describing are intimately involved in setting up someone to have spasticity. And when demyelination happens in the various tracks that are mentioned there, over time spasticity will develop. And this is a phenomenon that really, when someone has an acute central nervous system attack, usually spasticity is not present. Very rarely it can be. But it's really, over time, people will develop it. And so it's a little bit tricky in terms of monitoring people in clinic, because if someone has increasing spasticity, the first thing we're thinking about is, oh my goodness, are they having more lesions develop, right? Because that certainly can happen. But oftentimes it really is without new lesions. And it can happen really where you have a muscle and a tendon, spasticity can develop. I've seen it in the weirdest places. And it becomes important because if someone has diffuse spasticity and you're trying to treat with a whole bunch of different oral medications, you're getting side effects from the oral medicines, you're trying the non-pharmacological interventions, then we have to start thinking more invasive, including like a baclofen pump, for example. Now, what is interesting about spasticity, unlike some of the other symptoms, including other hidden symptoms of nervous system diseases, is that cold temperatures aggravate it. So we'll hear from a lot of people that, the summertime's the worst. That really activates a lot of my symptoms, even pain syndromes. But spasticity, it seems to be cold dependent. Similar to other pain syndromes, there's a variety of triggering things that you can see on the bottom there: stress, infection, pain. So if someone does come into our clinic with increased symptoms, it could be spasticity or something else, I'm making sure that there's not one of these triggers present. I mean, it could be a simple urinary tract infection that's actually causing this. So this is an incredible busy slide. I'm not going to go through it in detail, but this is just to hammer home the point again that with any of these pain syndromes and spasticity included, we need this multifaceted approach. So the oral medications, rehabilitation, Botox injections can be quite helpful. Seems to be more helpful in the smaller muscles, so not the larger muscles. If someone is having significant side effects, as I mentioned, to oral therapies, and their spasticity is really, really bad, then we'll think about some of the surgical interventions. Now, we're not cutting tendons as much anymore, and I'd say for individuals with higher disability levels who have contractures and that's interfering with just their daily routine hygiene, sometimes we'll ask the surgeons to look at that. But fortunately, I think with many interventions that we have nowadays, we don't have to go down that road. So intrathecal baclofen pump has been around for a lot of years. There is a pump now available that's MRI compatible. So that's very nice because we will send some individuals to get this. And some of the advantages you can see there, where if someone gets too much in the pump, you just change the dose of delivery, and so that's nice. In terms of the side effect potential, baclofen, if some of you are on it or have been on it, at higher doses can really cause significant cognitive fogging, can cause a significant amount of actually bladder retention. And so this particular way of administration, you can do concentrated doses of baclofen where you won't have some of those side effects. Some of the disadvantages, of course, it's hardware, right? You have to have a surgical procedure. This has to be put in. I've had a couple of patients where the catheters broke or have been dislodged, and that can cause baclofen withdrawal, which can be quite nasty and actually lethal in some cases. And you do have to get it refilled because the pumps are only so big, and the cost, it's not insignificant. So medical marijuana, a whole slide dedicated to this, right? So I'm in Maryland, where this is not readily available, but DC is. This is not new, right? So cannabis use has been widely used in various chronic illnesses, including chemotherapy-related pain, cancer pain, also HIV and AIDS-related pain. The challenge that we have is that the inhaled version, we don't have really great ways to measure, again, going back to that pain scales, measure how well it's doing. And what we certainly don't have nowadays, and hopefully we will, are studies in specific diseases to say, yes, this is a home run, we need to use it. There have been a couple studies recently looking at MS population, and I have some patients that do medical marijuana, that the pain levels and the spasticity, two of the things that seem to be most impactful, does seem to improve. However, the inhaled version seems to impact, for some people, their cognitive function and make them a little bit more foggy-headed, which, if you smoked pot when you were younger, maybe you weren't thinking as clearly when you were smoking. But anyways, so I think we need to do better studies, more studies. And when you look at the different components of cannabis in general, the psychoactive component of it is what gets people into trouble in terms of the cognitive dysfunction. It works really well for the nausea and vomiting, and that's why it's used in chemotherapy. So that's that THC. The cannabidiol, though, component is the one that we need to tap into more. And that's the one that seems to work the best on things like neuropathic pain. But unfortunately, the natural cannabis, the medical marijuana, has more THC than the CBD component. But there are actually a couple medications, one of which is FDA approved. Marinol, which some of you have probably heard of, has FDA approval for chemotherapy-related nausea, vomiting, weight loss, and HIV/AIDS. So I've used this actually in a couple patients who have had refractory pain syndromes, and I think for an individual it may help. Sativex, which is not approved for use in the United States as of yet, but is approved for use in other parts of the world. This is a spray that people will do in their mouth, and actually, at least the data that I've seen and some people that I've talked to, it seems to help. Now, just like any treatment, it's not going to help everyone, but yet it's another way that we can tap into pain syndromes from a different receptor, because cannabinoid receptors are throughout the nervous system, and this may be on the horizon, a different avenue to treat. And then there's another medication in this class that's not used that often because of the side effects. Now, tertiary pain, this is a busy slide, and given the time, I'm not going to go through this. I just want to impress upon you guys that chronic pain syndromes set people up for a lot of these issues: social, emotional, cognitive, depression, etc. And we really need to treat this in combination with the pain. Else, that vicious cycle is never going to be broken. And here's another hitting you on the head with this multi-D approach to treating pain. Now, of course, there are a lot of potential players that can get involved in individuals' care. And this can change over time. So depending on the need of the person, and this is not just for pain. This is really any symptom associated with a neurological condition. And so I really encourage people to try to endorse this multi-D approach because I have seen it change lives. So in conclusion, pain syndromes are ubiquitous in CNS inflammatory disorders. I would say it's probably one of the most challenging symptoms to treat. It's what I refer to as a hidden symptom. I reviewed very briefly that there are a number of associated symptoms that come as a result of pain syndromes, and there are various triggers, which many of you know well. And again, using a multifaceted approach, using both pharmaco and non-pharmaco interventions, at least in my experience, are needed. And having that multi-D approach is really critical. I wish there was a cookbook recipe that we could all follow an algorithm, say, okay, you got this pain syndrome, let's follow this pathway, and it works 100% of the time. Nope, it's not that easy, unfortunately. And so we just, you have to try one thing, try another thing, try a combination of things, and hopefully that can improve the quality of life. Thank you.